So I guess this is open for discussion. I've received a lot of interesting questions already. I'd like to take a chairman's prerogative to ask Dr. Madero about this Mesoamerican nephropathy. There was an interesting article in Epidemiology, the journal, by Saldana in 2007. And they looked at people with incident renal failure in North Carolina. And they found that they queried them in terms of soft drink consumption. And they found out that those people who admitted to drinking more than 2 cola beverages a day had double the risk of CKD than those who did not drink colas. And this was true in sweetened colas, unsweetened colas, and in non-cola beverages, the risk fat ratio was only 0.93. So I got interested in this because John Ball, whom I work with in this society, International Society for Hemodialysis, who does a lot of charity work in South and Central America. I don't know if you know John, but he told me that some of these sugarcane workers go out in the field with 6 or 8 bottles of Coke strapped around their belt during their workday, and this is what they use as a rehydrating solution. And for whatever reason, the cola companies have established a very strong presence in Mexico and Central America. At least that's what I'm told. Supposedly the consumption of cola is double that in Mexico and Central American countries than it is elsewhere. And of course, colas contain phosphorus. And if you give rats phosphorus to drink, their risk of CKD is markedly enhanced. So it's a long-winded preamble, but the idea is when you talk about all the possible factors, has anybody looked at this? I mean, I think this probably happens in areas where people rehydrate with solutions other than colas or phosphorus-containing beverages. But has anybody looked at the consumption of phosphorus beverages as a cofactor in this heat stress nephropathy that from Central America?
Well, that's a great question, thank you. I'm not aware of any study looking specifically at phosphorus and kidney disease, but I mean, the theory is interesting because, you know, we know that our population, at least, you know, the town Tierra Blanca where I visited and did the surveys, 3,000 milliliters of what they drink are sugary beverages every day. So I think there's a big confounder here because we have the largest prevalence of overweight, very high prevalence of diabetes and hypertension, right? Mm-hmm. And so we have this very huge epidemiology of all these causes of obesity causing kidney disease, but then we have the CKD of unknown origin. And I mean, I think, you know, our population, despite the fact that we studied the water and we found no heavy metals whatsoever, people are very much afraid of drinking water, and they'll feel safe drinking sugar beverages. But you know, the specific question about the phosphate, I think it's quite interesting, and I don't know anyone that has explored it. Thanks.
Good, thank you. Then there was a related question from the audience. I'm not really sure how it can be answered. It just said, can you expand on management strategies for these folks with Mesoamerican nephropathy in the context of multifactorial causes and tubulointerstitial pathology? What is current research focused on?
Yeah, so, you know, there's no current management, but what I know they've been doing, at least in El Salvador, so I think this is quite risky, but they give a tiny dose of ACE inhibitors before the shift, which, you know, obviously that's the risk of getting volume depleted and having AKI, but they give a very small dose. The recommendation is drinking 1 liter of water per hour. Mm-hmm. They get put on bicarb, and they get put on allopurinol, a lot of them. Because there's data that reducing uric acid and increasing bicarbonate or decreasing the urine pH increasing the urine pH with bicarb could actually be beneficial. And there's experimental data on this, but there's no clinical data whatsoever. And there's also data that says that even if you rehydrate with 1 liter per hour, these folks are still getting kidney disease. And this is unpublished data, but you know, we're not fully preventing it.
Thank you. So, that's good. The next question is to Dr. Rosner. Mitch, according to OPTN and UNOS policies, undocumented immigrants can be listed for transplantation. However, there are other barriers to centers listing them in the first place. And can you comment on it?
Yeah, excuse me. The barriers are largely financial, as I understand it. I'm certainly not an expert in transplant issues and undocumented immigrants, but my understanding, it's certainly in our state, it's largely making sure you can document that you have the finances to pay for the transplant, as well as assuring the transplant team that you have the finances to care for yourself and the medications afterwards. So that's my understanding of the situation in many transplant centers.
Good. And there was a related question, Mitch, about green cards. I mean, obviously, green card's different situation. Is dialysis for a green card holder in her 3rd year paid for only in the case of an emergency?
So there it depends upon the insurance status. Obviously, emergency dialysis will be provided to anybody, irrespective of their insurance or green card status. But for green card holders, it's going to depend upon whether they have access to insurance, whether they're going to be but they per se would not be excluded from other programs.
Good. Okay. Now we have a couple for Markus. 2 on 0K potassium. I think you sort of answered this, but I'll ask the questions again. The first question is, have you ever used 0K bath for CVVHD? And the second is, in your opinion, should the rule of 7 be changed to exclude 0K bath?
We never used it,
Yeah.
but centers are using it, and I think if you're confident to use it, and it might be safe. So that's what the literature said.
I know, I personally, we have different, when you're on rounds, you sometimes see patients who are from a different attending. And I've come on patients with in the ICU on a 0K bath on a monitor, and you see all kinds of strange things on the monitor, and then I've changed that to a 2 or 3K bath, and it just seemed to go away right away. And I was always afraid to use a 0K bath. But,
We don't do that.
Good. Mitch, you guys, what do you?
I don't use a 0K bath.
Yeah. What do they do in Mexico? Do they? No 0K bath.
Never.
Okay.
Well,
So
I've never
that's
used a 0K.
consensus. Okay, interesting question. I see some military personnel with large muscle mass and elevated CK and creatinine kinase, I presume, and decreased eGFR beyond the muscle mass effect on the estimated GFR equation. And this is probably from undetected pre-renal or rhabdo from March exertion. I'm not exactly sure what the question is, but of course, I guess this was to Markus. Maybe you can, I don't know.
Okay.
Rhabdomyolysis does occur, obviously, and it does elevate the creatinine beyond what you would expect from. How do you it goes? I guess the larger question is, in terms of estimating GFR on when to dialyze patients. Maybe this is, Lorien, a question for AKID. I don't know. Yeah.
We do cystatin C clearance then,
Okay.
so not creatinine-based formulas,
Yeah.
but rather to cystatin C-based formulas. We use it.
Yeah.
So whenever I doubt the creatinine-based estimation, so we look at the cystatin C, or we collect the urine, 24 urine sampling. Sometimes there are big differences between the GFR estimated either by using MDRD or CKD epi formula. We use cystatin C based, so there are big differences.
Excellent.
Probably this would be
Yeah.
an easy way.
Good. Okay, one is the I don't quite understand this question. This is for Dr. Rosner. Your estimate of the number of immigrants with ESRD seems counterintuitive in light of the healthy immigrant effect. Do you think renal failure in this cohort can be attributed to their time spent in the U.S., specifically their employment? I was sort of thinking about that a little bit when you were talking. Is there even a more different moral imperative if they develop renal failure as a result of their stay in the U.S. as opposed to somebody who comes to the U.S., maybe who had renal failure previously and is coming here just to for treatment because they can't get the treatment in their home country?
Yeah, well, I think both occur. I don't think we have good enough data to tell you how long a particular patient has been in the U.S. before they develop the ESRD and needs dialysis. The estimates, remember, they have a huge range in terms of possibilities, and they're based upon using data of the home population of what their ESRD incidence is, not what it is in the United States. So there's some very big assumptions in those numbers.
Good.
Can I ask a question?
Sure.
Maybe I was when I was thinking about the workers who get dehydrated and drink sugared beverages, my thought kind of ran to athletes like runners who we've actually studied and don't have a higher incidence of CKD, but do have multiple episodes of getting dehydrated, exercising, and using sports beverages, which are high in sugar, and they don't have that. So I was wondering if you had any thoughts about that.
Yeah, so there's a very interesting study where they had athletes go in the gym with high temperatures. So I didn't show this paper, but one group gets rehydrated with only water, and the other group gets rehydrated with Mountain Dew. Mountain Dew has the most fructose out of all beverages, sugary beverages. And what you see is that, and they get to do running at, I think, temperatures of 39 degrees Celsius. And the group that gets rehydrated with fructose actually gets AKI, up to 40% of them. So they do get AKI. And you see, like marathon runners, there's a paper in AJKD, they get AKI at the end of the run. So I think it's just that these workers are there every day for 8 to 12 hours, so it's repeated episodes of this without recovering that actually ends up in kidney failure. That's my personal take.
So now we have a lot for Dr. Dalrymple. We thought you were spared, but they came in at the last minute. Some interesting questions. First of all, and maybe some of these are clinical questions that others can comment on the panel. Are there data regarding the best time to initiate phosphate binders or ESA agents in AKID? Is this done as a case-by-case decision, or is there any type of policy in terms of this?
Yeah, so I think that's, I would argue, one of the areas of uncertainty, right? When you have sustained AKI, so AKI lasting weeks, then months, do you start implementing policies and procedures that parallel the care of ESRD patients? I don't think that's the strategy we would necessarily want to implement. I think it needs to be highly individualized, but these are areas that I would argue, and I'd love to hear the rest of the panel thoughts, are just understudied. I don't think we understand the optimal management of complications for prolonged AKI. And so I'll give you the classic example, because I ask people anytime I get a chance, I'll ask the panel, what's the right hemoglobin target for sustained AKI? They're outpatient, they're no longer in a hospital, they are presumably more mobile. You want people to have optimal physical function, but I don't think these are things we have good answers to right now, because a lot of the studies have focused on in-hospital care, optimal dialysis strategies, not necessarily management of all the complications that come from prolonged AKI.
Do you alter the recommendation in the standard of the unit in terms of anticoagulation for these patients?
So that's the individual prescribing physician determines the anticoagulation. And I presume it's highly variable depending on the individual and what their recent clinical course has been and their risk of bleeding.
Because at least acutely, initially, a lot of people will try and do these heparin-free. I don't know, Mitch, what you guys would do.
Yeah, when people, our center was one of the ones that you talked about. We typically, when they transitioned out of the hospital and entered our TechU, our transitional care unit, all of them were treated with standard ESRD protocols. So they started binders. We had the same goal, really no difference than an ESRD patient. The protocols were, we started the standard care for everybody. And anticoagulation was individualized.
The same is true in our hospital.
Okay.
Yeah.
So another question to Dr. Dalrymple, but maybe to everybody. Wouldn't the results of recovery from AKID be significantly higher if they were put on emergent PD? And I don't know, is Fresenius planning to do anything on the emergent PD as a way of, I mean, what happens in terms of?
So I will make a couple comments. As some of you may know, Medicare policy prohibits the use of home dialysis therapies for AKI. So that's only Medicare, and that is not universal. I think the challenge with home therapies, although I personally think we're going to start seeing more PD and AKI. I could be proven wrong in coming years, but as we grow home therapies in general, and I remember I was at a presentation a year or two ago talking about why don't we sometimes use PD for AKI. I think the challenge is most hospitals in the US do not treat AKI with PD. And so if it's not being initiated in the hospital and they're not being transitioned to like an urgent start PD, I think in the short term, we're not going to see a lot of PD for AKI, but I think it's an excellent question because you could argue it's more gentle fluid removal, it's very well tolerated. The challenge, as I showed in some of the slides, is many people take a couple weeks to be trained on PD, and depending on the anticipated duration of your AKI, you could argue that may not be the most effective approach and may or may not be in their interest. But home therapies are, I would say, rarely used for AKI on an outpatient basis. And I don't know, did your centers ever do PD for outpatient AKI?
We do it in Mexico, but you know, it's very different because we have a PD first approach, right? So there are patients being treated for AKI with PD, and then they just get discharged on PD, and they do very well, actually.
Okay. So now I have two to Markus Pirklbauer. One is, what do you do to a patient who's severe hyperkalemia but also has a very high BUN, and you're concerned about dialysis disequilibrium, but you want to lower the potassium? How do you approach a patient like that? Or do you guys believe in dialysis disequilibrium syndrome?
We believe because we start hemodialysis. If it's AKI, we start 2 hours, slow flow, using small filters. So
but now they have a potassium of 9. So in those 2 hours, will you get the potassium down in a sufficient amount and then to still be able to not excessively lower the BU? And I think that was
the question. Should we use 0 potassium? I would use K1 in that case. I wouldn't be that afraid of this equilibrium syndrome, but I would do 3 hours with K1 and then see what potassium went to.
Mm-hmm. Mitch, do you have any wisdom in this?
Yeah, well, in those circumstances, we've often done 1 or 2 hours of hemodialysis and then transitioned the patient to CRRT for a prolonged period of time and a relative, K2 bath to try to get the potassium down over a longer period of time, but at least get them quickly into a safe range. I think you can think of probably 50 or more different ways to do it.
Yeah.
And there was another question from Markus about this potassium gradient. There's been some articles that if you do monitoring, there's less arrhythmias, fewer arrhythmias. I don't know if there's any outcome data, but do you do any type of decreasing potassium bath business? We haven't. I don't think anybody has.
We don't.
Sort of. Okay. more things on, let's see here. Well, one was another question about adjusting the hemodialysis prescription in outpatient AKI. I was interested, there's an ongoing trial in England where they were concerned about recovery from AKI due to excessive fluid removal. And sometimes if they remove less fluid, the patient's kidney function tends to recover. I don't know if there's any thought or concern about that here in the US. But at least what I was told by, this is James Tattersall and that group, and this even happened chronically, that that some of these patients were actually below their target optimal fluid balance, and when they increased the amount of fluid that they let the patient have, they started to make urine, to the point that a couple of patients were able to get off dialysis for a certain amount of period of time. I presume you're not really looking at that because these patients get managed according to regular protocols, but I was just wondering if that's on your radar screen at all.
We have started to look at some of that because I do think volume management is critical in the setting of AKI and recovery. And I think we do introduce challenges when a facility, 99% of patients have ESKD and 1% have AKI, really helping people to understand how different that management strategy needs to be. You know, in the ESKD population, I think our nurses are often encouraged to challenge dry rate, right? Optimize blood pressure, minimize number of blood pressure meds, and I think the approach in AKI does need to be different. And we have spent a lot of time thinking about how you really optimize volume management. And I think it's challenging in AKI because you don't want people volume overloaded. That will impair their cardiac function and lung function. But I don't think you want intradialytic hypotension, high UFR rates, going below the dry weight, challenging the dry weight. So, you know, from my perspective, these are all areas where the care for patients with AKI needs to be highly individualized, and really the physician and nephrologist really driving very strict assessments of volume and what the goals are with fluid removal. And I'd be curious if, you know, UVA, what their strategy was in the TEC-U for volume management to avoid some of this intradialytic hypotension and other.
Yeah, it was basically individualized. I would say that the data you quoted, I think the problem with it is it's hugely confounded by residual kidney function. Obviously, the patients who have more severe AKI, no residual kidney function, no urine output, need more UF. The patients who are recovering have increasing urine output, they need much less UF. So I think those studies have lots of confounders that complicate it. But I do think it makes just good common sense that you want to avoid intradialytic hypotension and try to sort of nurse the kidneys through this episode if they have a chance of recovering.
Yeah, and again, we only have, you know, one LDO's experience and then what we've seen in Medicare beneficiaries, but we obviously can't look at blood pressure data. But I do believe, and again, the panel, I'd love to hear if you feel differently. We're going to be caring for these patients, I think, increasingly on an outpatient basis. And really, I think it's imperative that we help differentiate the care of patients with ESKD versus AKID in the outpatient facility setting.
One related question, Lorien, was about etiology. Do you have any data with regard to recovery from AKI as a function of cause of the AKI?
Yeah, we have not looked at that, but other studies have looking at etiology. But we don't capture biopsy data, for example, when it's done in AKI, or what I would argue, many of you have probably seen the ICD-10 diagnoses for AKI. I would argue they're not quite as granular as we would probably want. So my sense is that research is better done in health systems with more granular data on etiology of AKI and recovery. But I think clearly all of us know certain forms of AKI have a higher tendency to recover.
Excellent. Maybe one of the last questions from the audience, other than Egypt, has it been described, this is presumably for Mesoamerican nephropathy, has it been described in other desert areas or Middle Eastern countries with very high temperatures? although I assume that these countries do not have agriculture as their main industry. So I guess the question is the temperature effect per se. Have they shown similar patterns of unexplained chronic kidney disease or AKI?
Yeah, I mean, there has been a lot of descriptions of hotspots where there's kidney disease in China, in India, in Sri Lanka, in Egypt, and the big question is, are we seeing the same thing? Is it the same disease or is it a different disease? And that, I don't think me or anyone can answer this question. There's a lot of people in the Middle East that think that silica is what's going on over there, and there's others, for the Balkan nephropathy, it took a lot of years for us to understand that it was aristolochic acid. So, is it Mesoamerican nephropathy in Central America, but CKDU in the Middle East or in India? Is it the same or is it different? I actually do not know. I mean, we are trying to work together to have this like a minimal data set of capturing information, to have the same information, to do kidney biopsies, and to try to work together to try to standardize this disease. But I don't think we know yet.
So I think that's it for the audience. I'd like to ask the panelists if they have any questions from each other that they would like to ask, or nothing? No? Okay. Well, thank you all. Thank the speakers. It's a wonderful session, and I learned a lot. Thank you.